Hi, this is Dr. RAJEEV JAIN from Safe Site Center. Uh, Sharing another video. This is a patient who underwent retinal detachment surgery at our center followed by silicone oil removal. He developed cataract. As you can see, it's a brown cataract, hard brown cataract, and he was posted for surgery 6 months post silicone oil removal. You can see a few oil droplets which have migrated to anterior chamber. Uh, and as with any cataract surgery post VR, we have put an infusion cannula. Since the glow was not great, I thought I'll use this as a source for endoillumination. And once I put the endoillumination, you can see a bright orange red glow. So this is the advantage of putting endoilluminator. It gives a very good red glow, the background over which you can do your phacoemulsification. Standard 2.8 limbal incision, followed by staining of anterior capsule. And once the capsule is stained, viscoelastic was injected to remove the dye. And while injecting the viscoelastic, you can see the oil droplets, the residual oil droplets, they are also coming out from the main wound. So it helps in both the ways. Now, after this, as I normally do my rhexis with the capsular rhexis forceps, and I'm trying to make a circular big rhexis in this because it's a hard nucleus. We don't want a lot of pressure on the zonules, so I'm trying to make a large rhexis so that during phacoemulsification it can be the nucleus removal doesn't cause pressure on zonules. Once this is done, then hydration is done, nucleus is rotated, and I've gone inside with the phacoemulsification probe, and just a routine standard phacoemulsification was started. And you can see the advantage of endoilluminator. All the edges, they are illuminating because of endoilluminator, and the background red glow is wonderful. So divided into two fragments, and the first fragment was further divided into two more fragments. The fragments were rotated. Normally, another caution, when I'm doing these phacos, my bottle height is reduced to 70, normally, which I keep at 100 in signature by AMO. While I was dividing this, the bag appeared unstable, and as you can see, there was a zonular dehiscence on the nasal part, and whole of the bag with the nucleus was coming towards my port. Once I noticed it, uh, I injected viscoelastic, stopped injected the viscoelastic, and took out my phaco probe. And at this stage, I thought, since the zonules were intact in all quadrants, I made two more stab incisions, and I planned to put anterior capsular hooks in this eye. So anterior capsular hooks, they are blunt. They are just like iris hooks, but they are blunt ends, so that they don't pierce the anterior capsule, and they are longer. So first, anterior capsular hook goes inside. You tighten it a bit so that it supports the anterior capsule. You have to be very careful that you are under the capsule, not just under the iris. If you put it under the iris without going under the anterior capsule, the whole purpose is lost. So this is an attempt to stabilize the bag so that my phacoemulsification can be completed. And once this is done, you can't make them very tight, because once you make them very tight, as soon as the chamber deepens, the capsular hook comes out from the capsular bag. So after this is done, bottle height was further reduced to 50 because I didn't wanted the chamber to become too deep, and phacoemulsification was done just as a routine case. I was trying not to do much manipulations, because these manipulations can actually cause too much of turbulence and dislodgement of anterior capsular hooks. The good thing about this phaco, the highlight which I wanted to do was, you can see the red glow. It's a wonderful red glow considering what was there initially. This is the advantage of putting endoilluminator. I have that port which I have put endoilluminator, but it's a precaution just in case the eye becomes too soft. I can remove this endoilluminator probe and put infusion cannula inside this to infuse the eye. And you can see that anterior capsular hooks are holding the bag very well. They are under the rexus, and the phacoemulsification is going on just as you would do in any other case. The only precaution which we have taken is reduce the bottle height. And once last few fragments are there, you try to remove them the way you do it in a normal phaco. It's a bit hard cataract, and the last fragments coming out easily. And the bag is still there. The bag is still there. The anterior capsular hooks are holding the bag in its position. So this is how it looks once the endoillumination is off. This is how it looks when the endoilluminator is on. It's a huge difference, and this was to highlight this. After I've done this, I put a capsular tension ring. I do it with the injector, the steel injector, reusable steel injector, and CTR is pushed inside, and this is to give stabilization to the capsule. And once it is inside, we are ready for IOL insertion. Once you have to be careful with the IOL, you don't inflate the bag too much before putting the IOL. Once the IOL is put, you dial the IOL in the bag, and now this is the time. Once this is done, you are sure that it's in the bag. You remove the anterior capsular hooks before doing the IA, so that viscoelastic is still there, and you loosen both the capsule hooks and remove them one by one. So since the zonal dialysis was almost around I would say 150 degrees on the nasal side, I used 2. You can use 3 also, and you can use 4 also, depending on which quadrant and which area is involved. This is definitely a wonderful tool in cases like this. Then the routine irrigation aspiration is done, and this is how the case looks at the end of the surgery. There is small plaque, post-capsule plaque is there, which I am sure we can remove it with the YAG caps later. Infusion port, the trocar cannula is removed, endoilluminator is removed, the wound is pressed, the skull wound is pressed, and this is the end of the surgery. Thanks for watching. You can connect with us at our YouTube channel to see more challenging videos.